good afternoon to all. I'm welcoming you for the advanced module part 1, the respiratory fungal infection and the antifungal stewardship with Dr. N. Sandan. Myself, Dr. Bhunesh Raman, ID clinical pharmacist in Royal Cassandra Hospital, Coimbatore. I'm inviting Dr. N. Sandan for this session. Dr. N. Sandana, MD General Medicine and DM Infectious Diseases in AIMS and Consultant Infectious Diseases in Velamal Medical College, Madurai, and RSTMH Student Ambassador and WSPID Pediatric Infectious Disease. And he had a fellowship award in Organizing Secretary in TNIDC 2020-25. And it's very pleasure to meet you, sir, and welcoming you for this session, sir. Over to you, sir.
Good
Yes,
evening to
sir.
all.
You can.
Good evening to all. First of all, I'm inviting everyone to participate. Tamil Nadu Infectious Disease Conclave, upcoming October 4 and 5, Saturday and Sunday. It was going to hybrid mode in online and offline in Madurai location. It's basically for antibiotic uses in clinical practice, daily day-to-day activities. We are going to see. Please, if you possible, come and attend offline or online. Coming to audible bus. Hello.
Yes, sir, you are audible, sir. Go on, sir.
Done. Thank you. Today topic was respiratory fungal infection and antifungal stewardship. We are going to see. I'm going to see the case-based scenario what we are dealing in day-to-day activities. This was case 28-year male coming to us, generalized lymphadenopathy and hepatosplenomegaly and a high leukocyte count. There will be you went for bone marrow and genetic analysis. They shows M3 type of AML. The time they plan for antifungal, so at that time they plan for chemotherapy, and then during chemotherapy the chances of fungal infection or bacterial infection it will be high. They plan for starting antifungal prophylaxis. Why antifungal stewardship needed means there will be once right diagnosis you arrived, then only right drug you will give and then right dose and then right duration. Then only you'll get success. Otherwise, you will lose the patients and lose the success. What they started, they planned for AML midostaurin based chemotherapy. That time there will be fungal infection high. That's why they plan for starting antifungal. They started fluconazole. The problem with fluconazole, it will cover Candida yeast. It's not going to cover mold. That's what biggest problem. There will be what infection is common in AML induction phase. There will be mucormycosis, aspergillosis. What we are fluconazole going to cover, it will cover Candida. It won't cover aspergillosis or mucormycosis. Mold it won't cover. Then during the time they asked for ID opinion. That time we given for fluconazole because it will cover aspergillosis and mucor. The same time, because very disappointing statement here, there will be drug interaction. If you are going to give oriconazole is cheaper drug, but fluconazole it will be costly drug. The problem with oriconazole, there will be drug interaction. There will be much high with chemotherapy drug or some other drug, antipsychotic you are going to give, even PPI, even ATT, rifampicin. That time it will be drug level, it will be affected. There will be certain criteria have guideline they have for stem cell transplant or hematological guideline. They telling like there who are all higher risk, who are all medium risk and lower risk like the way which patient needed for antifungal prophylaxis. They have certain criteria. I'm not going very much deep. They based on that risk factor they going to give. Leukemia predominantly acute leukemia ALL, AML and graft versus host disease and severe immunosuppressed patients, certain criteria they have like the way. What is the challenge in prophylaxis or some other chemotherapy patients on? There will be always drug interaction. What drug interaction means? Voriconazole it will be much higher drug interaction with some other drug. Example, venetoclax or gilteritinib or something like drugs. Also, they have midostaurin-based therapy. Also, newer drug. These are all thing newer drug. Even though newer drug, there will be much drug interaction with voriconazole. That's why people's not preferred for voriconazole. They plan for posaconazole. Even nowadays, some places they're giving isoconazole. What is the other problem with voriconazole? There will be phototoxicity and hepatotoxicity, and even there will be QT interval prolongation also will be high risk. This I think disadvantage for voriconazole. Fluconazole I told what's the problem? It will cover yeast. It's not going to cover mold. That's why they cover newer drug. Newer drugs also there will be voriconazole have drug interaction. Why need prophylaxis means there will be always in leukemia patient there will be survival. It will be better and prevent fungal infections. Even nowadays, CAR T cells and the newer therapies, everything coming, but prophylaxis needed are not based on that individual case-based therapy for ALL, AML, graft versus discourse, some other thing like the way it will change. The problem with chemotherapy drug, there will be certain drug, it will be mold common, certain drugs will be yeast, it will be risk factor. Yeast will be common in certain drugs like the way. What's guideline? ECAL guideline, the recommendations are there will be drug of choice will be posaconazole prophylaxis. It's A1 grading. If you go fluconazole, it will be B1. In our patient, we change it to posaconazole. That during the time, patients improving well and uncontrolled disease status. And they plan for bone marrow transplant. At the same time, we told to continue posaconazole because there will be same risk factor for invasive fungal infections are common. The the pre-engraftment and post-engraftment period. What is pre-engraftment means? Before transplant. Or post-engraftment means after transplant. Pre-engraftment phase, there will be even fluconazole, it's enough normally. But case to case, it will be changed. Like AML or ALL, it will change. Like certain area, it will change guidelines. Post-engraftment period, it will be drug of choice only posaconazole. Posaconazole, why means the high risk for invasive fungal disease. That's why again I am telling there will be posaconazole will be drug of choice. Other risk factor also other fungal infection. Even though yeast or mold we are covering like the way there will be PCP pneumonia much higher area. There will be main problem we are going to get. In whatever patients on induction therapy, there will be severe induction therapy and bone marrow transplant. There will be even rheumatoid patients and severe immunosuppression like some other conditions. There will be higher risk for PCP pneumonia. Any patients HIV we are going to see in PCP pneumonia first diagnosis. You need to think. PCP pneumonia, there will be drug of choice will be cotrimoxazole. The HIV, it will be daily phases therapy we prefer than single dose, the alternate days. The other places will give for alternate days we are going to give. Other options also there will be cotrimoxazole. Other than cotrimoxazole, there will be pentamidine, dapsone, and atopine. There will be recommendations for that. But still prepared therapy for PCP pneumonia prophylaxis, it will be cotrimoxazole. Why cotrimoxazole means there will be resistance very low with cotrimoxazole. That's why we told them to continue cotrimoxazole and posaconazole. During that time, patients was what they given was the patients again came on treatment with posaconazole. During the time, patients came with febrile neutropenia. That febrile neutropenia during that time we evaluated patients. We given antibiotics. Patients not responding. Then even blood culture, urine culture, everything coming sterile. During that time, we give send for beta glucan. Beta glucans are high. They started gaspopungine, but patient's conditions not improved. Beta-glucan problem with what is beta-glucan? It will positive for maximum fungus, except like Cryptococcus, mucormycosis, or plastomycosis. These are three fungus. It will be beta-glucan, the biomarker for fungal infection. It was coming positive, except for Cryptococcus, mucormycosis, plastomycosis. The same time, what we examined, there will be patients who have crackles on the lung. The time we ask for CT chest and serum galactomannan, scatterman coming positive. Either we are dealing with right diagnosis or not. Beta glucan positive means there will be either false positive or not. We don't know. The same time, scatterman also coming like there will be false positive or we are dealing with true infection. There will be high, but values are high. The same time, we CT report came like halo sign positive. What halo sign? That one I will see. CT chest shows there will be consultation is there. Some consultation is there. But but patients on previously on posaconazole now on we and recently we changed it to 3 days back it will be caspofungin, but on posaconazole there will be breakthrough fungal infection, invasive fungal disease breakthrough on patients on prophylaxis, but patients getting fungal infection. It's called breakthrough invasive fungal disease. We asked for defaulter history. There will be detailed history defaulter or not. We don't know exactly. Again, there will be oriconazole. They will start or not. That one also still questions. Coming back to what is invasive fungal disease? Proven, probable, possible. What is proven means whatever histopathologically proven or sterile site like CSF or pleural fluid, it coming fungal positive considers proven invasive fungal disease. IFD means invasive fungal disease. Probable means markers are positive. That time we consider as sorry proven, probable, possible. There are things you need to consider. But possible there will be markers are not won't be positive. There will be clinical factor and host factor will be positive. For example, our patients like it will be patients on immunosuppression, some immunosuppression, or rheumatological patients, or something like cancer patients, or hematological malignancy. That patient, bone marrow transplant patients, consider as risk factor. Risk factor. You need to consider. Then clinical examinations consultation. That one also you need to consider. What some coming to basics, same like area. What is prophylaxis and empirical, preemptive, and definitive? Prophylaxis means there will be risk factor alone positive. Our case like hematological patient, there will be AML, infection means we start prophylaxis. That's called first consult we started. Empirical means there will be clinical, some radiological finding or clinical examinations consultation plus is there considered as empirical. Preemptive means plus biomarkers are positive. Definitive means histopathology positive or sterile site source yeast or mold, something you will consider. If not sterile site, don't consider. It will be reliable. The problem with investigations, X-ray or CT, what I are going to take, it's not 100%. It will be assume. It will be possibilities there, but not. It will be true infection or not. Bacterial or fungal, we can't come through CTs. These are all thing probabilities we are going to deal. Like this are one. There will be certain European societies or when need to suspect fungal infection, when need to give antifungal. That will be they divided some criteria like clinical features like CTs, what all finding, or clinical examination. So suppose you are going to bronchoscopy, what all findings is there, CNS radiology shows what function, what radiological finding is that. That one also they based on that they will divide it as EORTC. Again, EORTC, European Society, what they did, there will be Galactaman cutoff. Galactaman, there will be biomarker. Biomarker for invasive fungal disease. Invasive fungal disease, what all thing means? Mainly endemic fungus for aspergillosis, histoplasma, coccidioidomycosis, paracoccidioidomycosis, plastomycosis. Like the fungus, there will be endemic mycosis, it will be predominantly positive. Our place, what we are seeing, like aspergillosis and histoplasma, both fungus we are seeing. Otherwise, there will be biomarker gatamin I told. Other thing like Aspergillus PCR, it will coming positive in sterile site. That time you need to consider sterile site. Otherwise, you will consider one from blood or one from ball or two from ball, like the way. There will be different cutoff they given like even they what sample you are going to take blood or serum or CSF to place like the way they given. They divided like mucormycosis when will suspect, aspergillosis when will suspect, like Caesarea hereditary. Why I'm telling like radiological finding, it's not 100% true. We are clinical and then radiological and then biomarker and then we are PCR. Nowadays we are going to see whole genome sequencing. There will be based on that halo sign itself, very reliable finding for aspergillosis. It will be most of the time. But problem with halo sign, it is not 100%. It will be either viral or bacterial or MTB or parasitic infection also. Even non-infectious conditions, autoimmune or vasculitis also possibility. They have certain aspergillosis different types there. Reverse halo sign, there will be you see fatal you seeing that the consultation surrounded by haziness, it will be halo sign. There will be haziness surrounded by consultation, it would consider reverse allosine. This one also say it will be more specific for mucormycosis, but this is not 100% again. I'm telling like it will be infectious or non-infectious, bacterial or viral, whatever you are going to deal that one. Whatever I told, there will be possibility of different test for different sensitivity and different reliability, sir. I told beta-glucan, galactomannan, other tests are what is there? Mannan, anti-mannan test, and T2 candida. This test shows only five organism. It's not five candida, T2 candida. So that's why they given like, and PCR and other tests also nowadays standardized. Multi-top, multiplex PCR, and fish. And then nowadays we are going for whole genome sequencing, next generation sequencing, whatever sequencing we have. There will be different advantage, different disadvantages there. Conventional, it will be manual most of the time. It will be take much more time. It will be species identification. It will be very much difficult. There will be newer tests, sir. It's coming like PCR or sequencing like the way it will be coming positive. But problem is either colonizer or infection. It will be difficult to find it. There will be different sample pros and cons is there. But invasive sample or you are going to take non-invasive sample. Always go for invasive sample. It will be for diagnosis suspects. The problem with there will be patient. We need to convince patients. Another thing is money. That's all different thing that patients situations also that will be changed. What I am going to tell in clinical aspects in antifungal, there will be different as well site or like fluconazole mainly for yeast, it will cover. Itraconazole predominantly for endemic mycosis in stable patients. It's not for invasive aggressive stage. You need to de-escalate therapy may be considered like many places like histoplasma or chronic pulmonary aspergillosis, like endemic mycosis place we need to consider like voriconazole predominantly for invasive pulmonary aspergillosis. It won't cover mucormycosis, but posaconazole or isoconazole it will cover aspergillosis, mucormycosis, whatever it will work. The main problem with voriconazole, there will be drug interaction. That's why they introduce what they discovered. There will be therapeutic drug monitoring (TDM) they introduce. And then they have posaconazole. Posaconazole still contradict area. There will be either you need to TDM needed or not. Isoconazole, there will be data are favoring for no need for TDM, therapeutic drug monitoring, but still some limited area we need to do for isoconazole. The drug interaction you see drug interaction aspects for voriconazole, there will be much higher drug interaction we need to consider. That one. Posaconazole reasonably better. There will be different recommendation, different drugs you need to consider. Canada aspect, you need to remember this much alone, it will be enough. Clabrata and Cruci, Canada Clabrata and Canada Cruci, this two only, it will be biggest problem for assault resistance. Canada Clabrata and Canada Cruci, that's the two pieces, it will be different for that. Invasive aspergillosis, the drug of choice will be voriconazole. Now guidelines are changing. There will be posaconazole or isoconazole equal to voriconazole, even better because of there will be side effects are much less. Another thing is side effect. Another thing is there will be drug interaction. What side effect voriconazole? Already I told. There will be hepatotoxicity. There will be drug interaction. There will be photosensitivity. There will be tolerability also. It will come. For mucormycosis, for aggressive phase, the drug of choice will be liposomal abortion B. Will come back again. There will be some favoring of one stable patient. We need to consider posaconazole and isoconazole. There is still invasive phase. If there is mucormycosis, you need to consider aggressive therapy, amphotericin B. Some places there will be combination favoring. That place will be there. Coming back, our case there will be changed to voriconazole. It's correct or not? We are patients on posaconazole initially, then now started caspofungin and now oriconazole again coming back to you, the patient's not improving. Either we need to go for TDM or antifungal susceptibility testing. Is the some species it will be changed. For even aspergillosis, it will be resistance is there. That's what biggest problem with that one. Now coming like aspergillus flavors. It was susceptible to oriconazole coming like, but TDM was there will be zero point 0.5. It will be low. What we did, high dose. If we increase the dose, then patients coming, improving. Why you need a therapeutic drug monitoring means there will be prophylaxis and treatment dose. It will be variable for therapeutic drug monitoring. Therapeutic level, it will change for everything like oriconazole for 1 to 5, some places like 1 to 6. For itraconazole, it will be 0.5 to 4. Posaconazole, zero point 0.7. Posaconazole prophylaxis 0.7. Treatment, it will be 1. There will be different kind and different cutoff. There will be different method. Predominantly, they are using HPLC, liquid chromatography that they want. Like, suppose treatment means, again, I am telling oriconazole, there will be non-linear pharmacokinetics. It will be narrow therapeutic index. It will be difficult to produce, so it will be effect. It was difficult to identify the effect. That's what biggest problem. The oriconazole TDM, there will be either prophylaxis or treatment. It will be 1 to 5. It will change. Like posaconazole, prophylaxis 0.7, here 1. Itraconazole, it will be 1 to 5, predominantly 1 to 5. That's why they need to consider. If low dose, if below the level, you need to increase the dose. If higher level, you need to reduce the dose or stop based on the severity. That's one you have to consider. These things why we need to know about that. Certain fungus, certain place it will be, certain drug it will work. Certain drug it's not going to work. Like amlodipine B, if you go Aspergillus, some species like Terius or Aspergillus flavors, it will be some place it will be very difficult to work. Again, fluconazole I told like in be yeast it will okay, but yeast itself, clabata grossi, it will be difficult. Voriconazole, mucormycosis itself, it won't work. But posaconazole, isoniazole, it will work. Mucormycosis. Problem some places with even isoniazole, some places MIC it will be different. That's one you need to do like. That's what first case. Second case I'm coming to here. 34-year-old male. He is farmer coming to you. There will be history-wise bronchial asthma. They take an ADT and again in cough. There will be non-pulmonary cough. Sputum is not coming. Now dyspnea. It's again coming. It will be treatment in nearby place. Now they sending for investigations. Investigation shows there will be X-ray. There will be hyperactive airway. There will be looking like hyperactive airways. Nothing more specific we are seeing. But problem there, eosinophils are very high. Any fungal infection or parasitic infection in eosinophil will be maximum time it will be high. What we did work for TB and infection bacterial and other thing also we worked that. Neratoman even we thought fungal also it will be coming negative. But CD source there will be findings there. What we did, there will be right side central bronchitis according to CT finding. There will be obvious case of somewhere we send for IgE and eosinophil observed eosinophil count and aspergillus for IgG antibody. It's coming positive. IgE positive, IgG aspergillus antibody. It will be coming negative. But here see, the diagnosis was what is there? The diagnosis will be allergic bronchopulmonary aspergillosis. What type? The problem is coming. B. Bronchitis, central bronchitis is there. When will suspect allergic bronchopulmonary aspergillosis? This was questions. The patients with repeated cough with a non-pollen, that time you need to consider. Eosinophils are very high. The time you ask for IgE level. IgE level also high, then you have to consider. There will be different types also there will be there. What is the diagnostic criteria? There are different scores also there. When will suspect? I told like asthma patients, same like asthma patients. Children it will be cystic fibrosis. The time eosinophil counts high, observed eosinophil count high, you check for IgE and IgG level for aspergillus antibody. Specifically, you ask for IgG or IgE aspergillus antibody. IgE, sorry for disturbance. Sorry. Uh, what drug you will give? Either itraconazole or AVPA. It's either azole. What you will give? Like the way they asking. There will be obviously answer is no. No antifungal. You need to give non-antifungal. Non-antifungal means what you will give steroid. Initially you will give steroid. If not responding, then you add itraconazole. Second line will be itraconazole. There will be different treatment response will be there. ABPA means you will give itraconazole. That much you need to know. Again, this one's 45-year-old elderly male smoker, alcoholic, dyspnea. This patient is also productive cough. This patient productive cough. Previously, there will be non-productive. Now, cases coming with productive cough. There will be yellow glass sputum. Sometimes hemoptysis is also there. The patient's old history of tuberculosis and COPD, outside treatment also is there. You are taking CT shows right upper lobe cavity like lesions is there. Some cavity like lesions there. You are sending hemoglobins are low. You are working for sputum examination, bacterial, fungal, TB, everything coming negative. The patient is not improving. The what are differential diagnosis you will think about? Either we are dealing with drug resistant TB or NTM or nocardia, then acid pass basically. These are also common. And non-infectious, either vasculitis or autoimmune causes like the way we are dealing like the way. Still conditions are worsening. Right sided fibro cavity, the examination is there. Again, we are sending sputum examinations are negative. That time, what we'll do? The headache will be sputum culture. We are sent old first time we send the TB culture. TB culture now coming is negative. The problem is arising. Patients also not satisfied with the response. Then we send for IgG aspergillus antibody that time. Again, same the time we send for balls coming negative everything. That time Gataman coming zero point 0.8, borderline positive. The aspergillus fumigatus in growth. Again, that time will be IgG for aspergillus antibody. It's coming positive. IgG aspergillus antibody coming positive. Now the diagnosis is chronic pulmonary aspergillosis. Previously we seen AVPA, allergic bronchopulmonary aspergillosis. Now chronic pulmonary aspergillosis (CPA) we are dealing. What form we are dealing with? Chronic. There will be different form will be there. Our case is chronic fibrosing bronchos pulmonary aspergillosis. What when we'll suspect chronic pulmonary aspergillosis? Like ABPA, eosinophils are very high. The time patients looking like absolute eosinophil count it will be high. Here, when you suspect means there will be some like cavity or consolidation. That time you need to rule out for TB, nocardia, and NTM. After that, we will consider you will consider aspergillosis. What aspergillosis means? Chronic pulmonary aspergillosis. There will be underlying conditions also will be there. Whenever chronic pulmonary aspergillosis you are suspecting means old history of tuberculosis or COPD or ABPA patients or some ILD patients, that time you have to consider. Maximum time it will be the cavity will be there. Maximum time it will be there. Otherwise, it will be some nodule will be there, multiple nodule will be there. That time again you are sending for IgG as well as antibody, it will coming positive, but you need to rule out other conditions, infective conditions. You need to rule out. Then only it will be considered as aspergillosis. There will be different type will be there. What antifungal give? ABPA means always you give for steroid, then itraconazole. Here, chronic pulmonary aspergillosis means itraconazole. Nowadays, it's coming like itraconazole. Itraconazole dose means 200 mg Q8 early for 2 days, followed by 200 mg BD. How long will give? That will also will questions coming like. If 6 months you are giving, patients still no not responding. What are thing you need to think about in clinical pharmacy level? What we need to think about patients' compliance. So either taking or not tablet correctly. That only need to consider. Drug interaction. Already I told. Oriconazole like itraconazole. Itraconazole not much more like oriconazole. It will be drug interaction. But the bioavailability tool was not better. Oral bioavailability. It will be variable bioavailability. Nowadays, the cost also itraconazole high. That's why they started introducing Suba itraconazole. That one drug, newer drug. That's why they introduced Suba, super bioavailability. Then therapeutic drug monitoring level. Already I told 1 to 5 for prophylaxis and treatment. Both are all the same. Then fungal species resistance are not. Here, this one will be not much more important like invasive aspergillosis or invasive fungal infection like. Otherwise, when you think about super infection, like sometime it will be TB or fungal, it will be there. That's why we check for everything. It's coming like okay, everything okay. But TDM it will be zero point 0.8, lower size. That time what it was, there will be we given for extra thing. What we check for that one patient we are taking PPA with along with us. That time then we stopped PPA, then patients improved well. Water level itraconazole will improve means our patients also we added lemon juice. It will be contain acidic drink. It will be improving with well. Even Coke their own place it will be better. Other form of itraconazole will be itraconazole solution will be there. It not available by PPA. Again, there will be Tolsura, Suba itraconazole, super bioavailability. The drug is also no more drug interaction. Duration it will be take 6 months to 1 year. It will be 1 year. probably it will take 1 year to taking response. If you are not taking 1 year, it will be there will be relapse with higher availability. First case what I discussed means invasive aspergillus. First case itself I discussed. Second case is AVP, allergic bronchopulmonary aspergillus we discussed. Third case it was CPA, chronic pulmonary aspergillosis. Now coming back to mucormycosis. Now one more cases will be there. 4 or 5 cases we have. Mucormycosis also same like there will be when you are suspecting mucormycosis means same like COVID or influenza or nowadays influenza also is start high on immunosuppressants. Even cancer patients you need to consider and any immunosuppressant, severe immunosuppressant you need to consider like the way. The problem, the steroid and diabetic patients is will be very high. That's why ROCM, rhino orbitocerebral mucormycosis is very, very high. Other places like lung and renal also, renal abdomen also, it will be very, very high. Based on that lung means lung symptoms, there will be CNS means CNS symptoms, there will be intestine means intestinal symptoms will be there. You need to always think about broad mind, either infectious or non-infectious, bacterial or fungal, that will also need to consider. The treatment aspects like mucormycosis, always the drug of choice will be aggressive treatment. The drug of choice is liposomal amlodipine B. If liposomal amlodipine B not available means you think about emulsion. If emulsion is not available, then conventional. Nowadays, newer form is coming like liposomal and emulsion and conventional. Nowadays, oral amlodipine B also it's coming like oral liposomal amlodipine B also now coming back. If any places like severe places, you need a better grade one recommendation, then it will be amlodipine B. If patients are responding well, you need to adequate source control into do. If lung means there will be you need to lobotomy if needed, we need to consider. If ROCA means debridement, adequate debridement we need to do. Otherwise, it will be spread very fast. Even renal means nephrectomy needed for these patients. Once stabilized with liposomal amlodipine B, then we need to give switch over to some other drug. That time you will consider azole. Azole, what azole preferred means Voriconazole is not going to work in mucormycosis. At least you know this much today. If voriconazole is not there, what will give? Isoconazole or posaconazole? Isoconazole is preferred drug than posaconazole. It was much less drug interaction, no need for TDM, therapeutic drug monitoring. That's why I'm telling like this was different type, different formulation. Liposomal amlodipine B, liposomal amlodipine B, high dose you need to give, or even we given 10 to 12 mg per kg we given to patients. Emulsion up to 3 kg, 3 mg per kg we given. Deoxycholic was given for 1 to 1.5 mg per kg. Other options are isoconazole. How will give means loading dose. It was Q8 200 mg Q8 early for 6 doses followed by once day. For posaconazole 300 mg day 1 BD followed by OD. The salvage therapy it will be different upon the patient's condition we need to consider like the way. Amphotericin B side effect like voriconazole or azoles like the way we discussed, there will be always electrolyte disturbance like magnesium and potassium. Potassium is much more common, hypokalemia. Other aspect, infusion. So whenever you amphotericin B, infusion reactions you need to consider. Other thing is nephrotoxicity, aka it's very, very high. Acute tubular necrosis is very, very common with that one. This is something we need to monitor. Even CBC anemia also will be common. Coming back to last case, there will be histoplasma. When you suspect histoplasma, this one also endemic mycosis. In our place, common or not, it will be common. If you have yeast and a mold form, two different types will be there. There either will be there will be different types of psoriasis there. Acute, it will be very, very rarely we are seeing. Like asymptomatic also we are very rarely seeing. We are seeing chronic pulmonary histoplasmas. We are seeing much more conditions like when either it will affect there will be lung also same like there will be patients have lung cavity or multiple nodule there will be histoplasma is with there. When we suspect means there will be adrenal also there will be one of the mass like lesions will be there. Underlying immunosuppression patients only. When will need bone transplant patients or bone marrow or renal or liver transplant or immunosuppression patients that will be common. Whenever suspecting histoplasmosis, always go for brain also. Brain will be disseminated, disseminated lesions will be common. Sorry for interference. Sorry for interference. There will be cavity and multiple nodule in histoplasma. There will be much more common. Other places I told like HIV patients it will be seeing much more cases. Same like as invasive fungal disease, there will be neutropenia, graft versus host disease that will be there. Pancytopenia, there will be bone marrow, adrenal, lung, and brain. These things you need to know histoplasma aspects. Bone marrow suppression very common, and lung aspects. Other main point is mediation and lymphadenopathy, much more common area. There are different tests is there. Either you go for we what we are using means there will be histoplasma urinary antigen. Routinely we are using that histoplasma urinary antigen. Other thing bone marrow bone marrow biopsy it will be better choice also. When not suspecting galactoman positive, not only aspergillosis, you need to think about histoplasma also. Even culture also it will be coming positive. There will be much more better. If acute case, there will be treatment. Mild cases, no need to treatment. Mild to moderate. If immunocompromised, may consider antifungal. What antifungal you will give means itraconazole. Itraconazole better than other drug. If severe disease or disseminated disease, we will need to give amputation be initially loading dose for 2 weeks, and then we need to give for itraconazole, de-escalating therapy, disseminated drug. HIV we are giving much more common because how it's spread by it will be pigeon. Predominantly pigeon area wherever it will be there, we need to consider like the loading dose I told 200 mg 3 times a day for 3 days means 9 doses. Then 200 mg BD. Suppose pregnant woman coming, what will do? That's her question will come. Pregnant woman whenever coming like you consider like pregnant woman coming like you have to consider ambotesin B weekly based therapy. This much I will end my slides, my session. What I'm telling to do means there will be more update for the infectious disease diagnosis and treatment aspect. For clinical aspects, we are going to conduct Tamil Nadu Infectious Disease Conclave TNIDC 2025 in October 4 and 5 coming Saturday and Sunday. Hybrid mode, online and offline. Please try to participate. Thank you. Thank you so much.
Thank you so much. It's a very wonderful session. It's a really interesting session for the clinical pharmacist.
Thank you.
Hello, sir. Could you audible, sir? My voice is audible, sir.
Thank you, boss. Yes, boss,
Yeah, yeah.
audible.
It's really interesting, sir. It's really interesting, sir. I have some questions regarding the antifungal stewardship and the aspergillosis, sir. Can I, sir?
Yes, please proceed.
Yeah, yeah, sir. We have like we will always suspect the fungal infection, the neutropenic host, or a patient have immunocompromised patients only. We will suspect the fungal infections more likely. But when a patient have a culture negative fungal infection, how we will describe that, sir? What are the empirical therapy we have to choose when a patient have a like a PDG is high and there is a no cultures? How can we select that appropriate antifungal?
There will be like invasive candidates. What you're seeing means pediatric gluten positive means there will be invasive candida you are suspecting. And there
Yeah,
will be suppose lung lesion means there will be you are not dealing with Canada, you are dealing with aspergillosis. That only you need to know. Positive wherever positive, where it will come negative. That's only you need to know. There will be beta glucan. It will be better for negative predictive value. It will not for diagnostic. It will be to rule out negative predictive value means you have to rule out. That's what meaning. Invasive Canada, when we will suspect means there will be patients have some risk factor. There will be major abdominal surgery. Whenever patient went for major abdominal surgery, major when you are feeling like the way, that time you have to consider. Otherwise, patients have multiple line, multiple device,
okay.
and patients have multiple antibiotic. What we are doing in our practice in India, that's what thing.
Yeah.
Then only then other factor like patients and sepsis, definitely they have sepsis will be there. That time otherwise other point is there will be some focal urine somewhere you getting Canada, that time we'll consider. Whenever patients is with multiple antibiotic, like my case, like I told risk factor, that time you have to consider 2 or 3 risk factor. That time you have to consider like. Otherwise, it will be whenever beta glucan simply positive, you can't treat. Like there will be false positive, so much conditions will be there. Even galactaman also same like I told like conditions. What all thing lungs you need to do. That one conditions you need to think about strongly. Everything have some limitation markers.
Yeah, yeah. So I have another question also,
Hmm,
sir.
yes.
What are the major challenges while differentiating the colonizer and the true pathogen, especially in the fungal infections? It is a colonizer, and we don't have to treat. We should have to treat like that. At the starting stage, we didn't treat it due to we will consider it is a colonizer. But after patient goes to crash or something, he will get some febrile. Like when we have to choose it's a colonizer or true pathogen.
Excellent question. The problem with Canada, what we are dealing, what we are seeing in day-to-day activities, there will be Canada don't treat in sputum. Whenever you are giving sputum, there will be no 99.99% there will be lung no more infection in Canada unless proven biopsy. I won't accept. That's our biggest problem. That's one. Second thing is urine. Patient in Canada, you are treating in Canada. Every AC you go and it will be there. Every hospital it will be there. I'm not telling you like this hospital, this hospital. Like you see there will be urine culture positive, they will start Canada. It's not like simply you need to change the catheter, it will cause colonizer. And if you have still doubt, you send for repeat culture. But it will be here also 99% it will be negative unless biopsy proven that area. Third thing, it will be skin. Skin we are taking swab. Swab also it will be maximum time it will be carbonate. Three things don't treat in Canada aspects.
Treat.
For other
Yeah.
fungus like area, simply you are dealing with sputum or culture, you don't go for aspergillus is there in the sputum or urine or something is there, don't treat. It will be colonization or contamination much more time is very high. Always there will be you, that's why I put it like invasive fungal disease unit because biopsy it will be proven. Biopsy is there whenever otherwise sterile site like plural or ascitic fluid or you consider CSF fluid, then only you consider like for probable cases I told like markers are positive, then other places coming positive PCR. Then only you consider. Suppose is coming fungal means you would consider. But urine and non-sterile site it always you know to think twice before starting antifungal. That's what I need to say.
Yeah, yeah, yes. I have some another questions also. We have like we have a case like when a patient have a neutropenic patient have a growth in urine for candida. It is a azole resistant, fluconazole resistant candida or is a candida parapsilosis. Like how can we treat that, sir? Like candiduria, how can we have to treat? Because the fluconazole is the high urinary concentration, but apart from fluconazole there is nothing.
The
How can we have to?
Yeah, according to Candida, I want to tell two things. So urine, it will be most of the time it will be colonizer one thing. Unless cyst is there, other bacterial is ruled out. Then only we need to think. You need to change catheter again. You have to send culture. If coming to I, so then only you have to consider the time one thing. Another thing is susceptibility method. For antifungal susceptibility, then what we are doing it was wrong method. So, we are going to go white egg or multi-top. That's what we are doing. That's what wrong, not accepted method. It's not accepted. Whenever you are suspecting resistance in fungal, always go for manual method. It will
Okay.
be, it was antifungal surgery. Machine needs to be not at all accepted method. There will be microbroth dilution or macrobroth dilution. There will be different methods there. Microbroth is preferred. Microbroth dilution method. It will be only few centers doing right now. I think in primary city only they're doing like the place. That's why I'm telling like whenever suspecting
Yes,
means
yes.
always go for microbath dilutions. Otherwise I won't accept that one concepts are called machine rate resistance something. Second thing is suppose in case resistance, even you are telling correct way, fluconazole resistance means in Canada, what drug urinary penetration is better? You are asking like. Amphotericin B, if you ask, means liposomal conventional emulsion. Conventional is better the urinary penetration. Reasonably. Before amphotericin, but after that,
Yeah.
liposomal it will be
Yes.
much less. Then amphotericin B is reasonably poor in the urinary penetration usually. What will be better means there will be flucytosine. Flucytosine, that drug also antifungal, it will be reasonable
Yeah.
penetration is better. Other thing is echinocandin. It was reasonably better. Combination therapy we need to consider like your case.
Yeah. Okay. 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 Sir, it's my last question. How we have to fix the duration, sir? Durations for antifungals in mucormycosis, in aspergillosis, in aspergilloma. How we have to like fix the duration?
For Candida, blood culture negative after 14 days. Once culture negative, initially you need to give for injection, echinocandin, Canada, and then you need to check for repeat blood culture. Usually they asking for every day. It will be very difficult to send. At least alternate days you need to consider. Once culture negative, after 14 days, you need to stop echinocandin 2, then switch out to fluconazole. Like the way guidelines are favoring. But what we are doing practice means at least source control. Wherever abscess is there, at least you drain and remove the risk factor. Then you need to switch over like the way we are doing in practice. It will be some places like it will be variable. Guideline it will be here this place even I'm not convincing like the way. Second thing it will be if you ask like aspergilloma simply source control itself enough. No need to give any antifungal. Sometimes you need to whenever suspecting aspergilloma in like what we are seeing in right now in my place, we are there will be chances of chronic pulmonary aspergillosis or invasive pulmonary aspergillosis we need to rule out. It will be simply aspergilloma is the radiologically we can't rule out for that patients. What we are dealing with like repeated patients, that's one way to consider. For chronic pulmonary aspergillosis, I told 1 year, 12 months. For IPA, invasive pulmonary aspergillosis, 3 months. So according to make or microsis, there will be biggest, very biggest challenge. There will be source control. The source control it will be need to adequate. Then only we need to give for amputation be for duration. It will decide. It will be cumulative dose. They will give like it will be difficult to judge for individual. We need to give for individual patients. It will change. Then we need to switch over to oral drug. Once patients stabilize, then we need to go to oral therapy. It will take depends upon patient. It will be very difficult to tell. Some patients take years or so. It will be for histoplasma. I told like with disseminated infection, we need to give for 6 months to 1 year. We are giving like okay.
Sir,
Hmm.
sorry, I'm audible.
Hmm. Yeah, audible, please.
Yeah, yeah, sir, yes, sir. Sir, thank you so much, sir. Thank you for this wonderful session, sir. It's really interesting about the antifungal stewardship and the respiratory system caused by the fungal infections. Thank you so much, sir. And
Thank you, boss.
sir, thank you, sir.
Thank you, boss. Thank you.